Hello, welcome to your Breathe Easy education. My name is Sarah. I'm one of the respiratory therapists working in Breathe Easy in Red Deer. Today we're going to be talking about pulmonary medications. So today, and this corresponds, with if you're working through a binder, this corresponds with section 6 of your binder. So there is a one-pager, an awareness exercise in there, which we will be talking about right at the end. So today we're going to cover benefits and beliefs related to all of your respiratory medications. That's puffers, pills, injections, and otherwise. We'll break down the different respiratory medication types, including actions and side effects. So, questions to pose to yourself. Do you know what medications you take for your lung disease specifically? If you're able to raise your hand and say, yes, I do, that's awesome. And if you're not, well, that's why we're here today. Okay, so at the end of the presentation, I hope that you have a better understanding about what you're taking and what its effects are in the lungs. And generally speaking, when we know why we're taking something, we're more likely to take it like we're supposed to or as prescribed. Here's another question for you. Do you know how each of your medications works? So if you have had a really good pharmacist or maybe some respiratory education in the past, you might be able to raise your hand on this one, and that's awesome. And if not, again, that's why we're here. Which one do you use in emergency situations? So which is your rescue? If you said Ventolin, yes, you are correct. And it's important to note that Atrovent, and we will learn about that one later, can also be used as a rescue. I had a really interesting conversation with one of our local respirologists, and he said back in the day, Ventolin and Atrovent hit the market, and the pharmaceutical company that owns Ventolin did a better job of marketing it to physicians as a rescue puffer. So that is why today it still continues to be the one that's most commonly prescribed. But Ventolin and Atrovent can both be used as rescues because they start working right away. And we'll learn about that here in a little bit. So, do you believe your pulmonary medications are effective? So this would be, do you feel like your symptoms are better? Do you feel like it's preventing chest infection? Do you feel like they're improving your quality of life? Question to pose on yourself. Do you believe it's necessary to take your pulmonary medications regularly? So hopefully you said yes, but if you were kind of like, I don't know if they're really working, we'll learn about why that's important, especially with one of the medications here in a little bit. Do you have any concerns about taking your pulmonary medications? So sometimes people have a bad experience. You know, there's one gentleman that is in this current program that had a really, really bad adverse reaction to all of the puffers that he trialed. And sometimes that happens, right? So not everybody can take them, unfortunately. The other most common thing I hear is questions and concerns about inhaled steroids. You know, is that going to make my muscles all big? Is that going to harm my bones? Like, what's happening in there? And we're lucky in this day and age because the inhaled medications that we take are at a low dose that's pretty much absorbed and utilized in the lungs only. So we don't really see a whole lot of systemic or in the rest of our body side effects from that. But that being said, it's always possible. So if you have any concerns about the medications that you're taking, you're welcome to talk to me. You're welcome to take that to your family doctor. Or if you have a good pharmacist on your team, they can often answer those questions as well, okay? So the idea is that we're not just avoiding taking them, but not finding an alternative. There are a ton of medications on the market nowadays, and we can work with you to find a regimen that makes you feel better without causing a whole lot of side effects, or if any would be better. So we'll talk about the different medications types. We have bronchodilators. So as the name suggests, dilation of those bronchial tubes. So when we talked about all the different types of chronic lung disease, we talked about those bronchial tubes a lot. Bronchodilators are working on that smooth muscle in the bronchial tubes specifically, okay? And there's two kinds of those. There's anticholinergic and beta-2 agonists, okay? So those are two different receptors, but the idea is the same. They expand and relax the smooth muscle in the bronchial tubes. We have anti-inflammatories. As the name suggests, it helps to combat and reduce the inflammation in your lungs that's secondary to your lung disease. We have antibiotics. We'll talk a little bit more about those. And we have others. So this includes add-on therapies. This includes, and we'll also talk about vaccinations as well. So bronchodilators, as I mentioned before, these relax the muscle around the airways, so the bronchial tubes specifically. This helps to widen the airways to allow better airflow. So it doesn't actually make them wider, it just allows them to be the size and shape that they're meant to be. And when you have normal airflow in your airways, you will not feel short of breath, right? These medications can relieve shortness of breath, chest tightness, and wheezing. And we've seen this picture before, but the top is a cross section of a normal bronchial tube. You can see the smooth muscle is nice and relaxed. The inside of the airway is as wide as it should be, nice and patent. On the bottom here, you can see the smooth muscle is constricting around the airways. So in this picture, you also see inflammation and mucus production, but it's important to note that bronchodilators only work on relaxing the smooth muscle. Okay, so a question I always ask at this point is, if the reason you're short of breath is not muscle restriction around the airways, will your rescue puffer or Ventolin help? No, it probably won't, unless you have a little bit of placebo effect, meaning you take the puffer, so you've done something, so you must feel better, and our brain will tell us that we feel better. But if muscle restriction around the airways wasn't your problem, say your problem is inflammation, taking Ventolin might not physiologically help the problem. Another important thing to note is if you're not sure if this is your problem, one way that you can tell is talk to your respirologist about your last pulmonary function test. At the halfway point, they give you 4 puffs of Ventolin. Then you repeat the test. If your volumes and flows improve by a certain amount, that's what's called partial reversibility, meaning taking a couple puffs of Ventolin improves your lung function enough to be clinically significant. So that also means that part of the problem was muscle restriction around the airways. Okay, so I always say put them to work, get them to show you that pulmonary function test and explain what's going on. But a lot of people, especially with COPD, because the problem is damaged and floppy airways, not necessarily smooth muscle restriction, a lot of COPDers take Ventolin and they're like, I didn't really think that did anything. I don't feel any different. Some do, but some don't, right? So it's never a bad thing to try and it's never a bad thing to have, but it doesn't always solve the problem. And that just goes to show there's more than one reason why we can feel short of breath, okay? So there are fast-acting bronchodilators. So these ones are called our rescue puffers, our reliever puffers. They start working right away. So if you're feeling acutely short of breath, you take these, it starts working in about 5 to 15 minutes, but they're short lasting. So my textbook said 4 to 6 hours. Here it says 3 to 6 hours. What's important to note is that it's not going to give you lasting effects all day, only short term. So that's why it's called a rescue. You feel short of breath in the short term acutely, you take your puffer, you feel relief, on with your day, right? So here's some examples of fast-acting bronchodilators. It's important to note, and I'll introduce the term monotherapy here. When you have one medication in one puffer, that's called monotherapy. So our Ventolin is monotherapy that comes in MDI and DPI. We'll discuss what that means a little bit more when we talk about puffer technique. We also have a Bricanal and we have Aeromir. Okay, so these are fast-acting bronchodilator monotherapy. There are what's called fast and long-acting bronchodilators. So these start working immediately, so they can still be used for our rescue, but they last longer than Ventolin does, so 12 to 24 hours. We have Straverdi, Oxys, and Onbreeze. So these can be used as rescue as well as controllers, and we'll discuss what controllers are here in a little bit. And again, these are monotherapy. All right, so that was those. The last two slides were the beta-2 agonist bronchodilators. Those work on the beta-2 receptors in your lungs. When we talk about side effects, we'll learn that there are also beta-2 receptors in your heart. The other class of antibiotic or bronchodilators is anticholinergic. Most of these are slow acting, so you can't be used for rescue. Everything but Atrovent. So we learned that Ventolin and Atrovent are both fast acting and short lasting, so they can be used as rescue. So it's a little misleading having it all on the same slide, but Atrovent is a short acting anticholinergic bronchodilator, and all of the rest of these examples are long-acting anticholinergic bronchodilator. So these are all monotherapy as well, meaning one medication, one puffer. In this day and age, because we have some really good combination puffers, it's not as typical that we see monotherapy as opposed to dual or triple therapy. But it is important to note that they are still available. If you do have adverse reactions to any of the combo puffers, you can break the medications apart as well. Okay, so Sebree, Ceravent, DPI, Tudorza, Incruz, and Spiriva HandiHaler, and Respimat. Bronchodilators combined. So these guys have both beta-2 agonist and anticholinergics. Inspialto, Duaclear, Anoro, Altebro, and Combivent. Important to note that Combivent has both short acting. So it has Ventolin and Atrovent. So this is the only one that you will likely be taking 4 times a day if it's prescribed. The rest are 1 to 2 times a day. Okay. But again, because we have excellent triple therapy on the market now, it's getting less and less common that you will be prescribed just a combination bronchodilator, but it is good to have options, right? Depending on how you're feeling during that trial and error period with your doctor or respirologist. Let's talk about some of the bronchodilator side effects. So with any inhaled medication, because most of the effects are in the lungs only, you don't typically see a lot of side effects. That being said, some people are very sensitive to the beta-2 anticholinergic or the beta-2 agonist effects. And that is because we have some of the beta-2 receptors in our heart. So if you're really sensitive to the effects of Ventolin, most of the things you will feel have to do with the increased effects of your heart. So tremors, rapid heartbeat, headache, nervousness, anxiety. This would be, unless you're really sensitive, you'd have to take many puffs in order to feel those effects, like 40 puffs of Ventolin in a day, sometimes some flushing as well. Some medications may also cause dry mouth, bitter taste, and eye irritation. So it's sad that we have to say this, but do not spray your puffer in your eyeball. That might cause some adverse effects. The dry mouth and or bitter taste has to do with the anticholinergics. Those are also considered drying agents. So some people are very sensitive to the drying effect of those puffers, okay? But generally speaking, most people can take bronchodilators with little to no effect other than in the lungs, and that's a positive bronchodilation. Oral bronchodilators. So these guys have been phased out because of their difficulty to properly dose and side effects, as we'll learn here in a little bit. But every now and then I come across a COPDer that's been on an oral bronchodilator for like 30 plus years. They've got their dose tweaked perfectly. And in that case, if it ain't broke, don't fix it, right? But we're not going to see these prescribed as commonly nowadays, if at all. And it'll be obvious here in a little bit. So these guys are slow acting, long lasting. They work the same as other bronchodilators to relieve that shortness of breath and wheezing. They can be taken with other bronchodilators as well. They must be taken on a regular basis, same as all of our other controllers. This is where it gets tricky. Blood tests need to be done regularly to monitor levels and dose. Many potential interactions with other medications and conditions. So the most common example was theophylline, that was marketed as Theodur. It's an oral pill. Let's talk about the side effects. So the most common side effects that may occur: nausea, anxiety, vomiting, tremors, diarrhea, irritability, headache, insomnia, and at toxic doses, heart arrhythmias, coma, seizures, and death. So because of this, and because there are so many other better inhaled medications on the market, oral bronchodilators have been phased out. Makes sense, right? Alrighty, so that was bronchodilators. So remember, working on the smooth muscle to relax the smooth muscle to allow that airway to be as big as it's supposed to be. Anti-inflammatories now, these prevent and reduce inflammation in the lining of the airways. In COPD, these medications can help prevent exacerbations really in any lung disease. You know, some of the restrictive lung diseases have an inflammatory component as well. So whenever you have that unmanaged inflammation in the lungs, you have increased mucus, you're at a higher risk of exacerbation and chest infection. So anti-inflammatories will help to mitigate that risk. And it'll also help you to feel better. These must be taken as prescribed to be effective. So these guys are tricky. We as humans like to feel an immediate response to what we're doing, instant gratification, right? That's not the case with anti-inflammatories. These are working in the background to produce what I like to call the blanket of protection in the lungs. So these are controllers or preventers, meaning you won't feel the effects of them right away or at all. But if you're taking them regularly, you will look back and say, oh yeah, wow, I've had more better breathing days and bad breathing days in the last 6 months to a year. I haven't had as many exacerbations in the last 6 months to a year. So it's not those things that we can feel right away, but it's more kind of a reflective, oh yeah, you know, things have improved over time. It's important to note that it takes at least 4 weeks of regular use to build up that blanket of protection in the lungs. So if you have a puffer that has an anti-inflammatory medication in it, and you're not taking it regularly, you know, here and there, missing a few doses, not really structured with how you're taking it, it's probably not working at all. So I always suggest take these with faith. You're not going to feel like they're working, but they are very, very important in the overall management of your lung disease. Okay? So, and again, here's that picture, but you can see on the bottom here that smooth muscle is still relaxed. So anti-inflammatories have no effect on the smooth muscle like bronchodilators do, but inflammation in the airways is what it's treating. So when we have increased inflammation, that airway narrows, so we'll still feel short of breath. And we also have mucus production as a secondary effect of that inflammation. Okay, so that is what anti-inflammatories are specifically treating. The other word for these is corticosteroid. The term steroid gets a really bad rap, but just know that at low dose, inhaled, you won't see any of those systemic side effects. And we'll talk about that here in a little bit. Here are some examples of anti-inflammatories. So like I said, these are preventers or controllers because they must be taken long-term for that blanket of protection. So these are all monotherapy anti-inflammatories. So one medication, one puffer. We have Pulmicort, Qvar, Flovent, Alvesco, Asmanex, and Annuity. So that was anti-inflammatory monotherapy. Let's get into some of the combo puffers. So we can get bronchodilation and anti-inflammatory in the same puffer. Here's some examples. Flovent is the anti-inflammatory. Ceravent is a long-acting beta-2 agonist bronchodilator. Ooh, that's a mouthful. And together, those produce Advair and Wixela. We will learn and watch some videos on how to take these in the next presentation. And another example here, we have Pulmicort, anti-inflammatory. Oxys, that's that short and long-acting beta-2 agonist. Together, those make Symbicort. Okay, so combo puffers, bronchodilation, anti-inflammatory. Here's a couple more examples. So we have Breo, Atectura, and Zenhale. So bronchodilation, anti-inflammatory effect, same puffer. This is what's getting to be the most common for our lung disease management because we've now streamlined your puffer regimen. All of these separate puffers are now together in one super puffer. Most of these are one and done, or one in the morning, one in the evening. About 5-6 years ago, Trelegy first hit the market. It was very exciting because now you have both types of bronchodilation, your beta-2 agonist, your anticholinergic, and your anti-inflammatory in the same puffer. It's taken once a day, one and done. Couldn't be easier. So what we found is that a lot of people really, really liked this, but there were some people who couldn't tolerate this. So at the time when Trelegy was the only thing on the market, if you couldn't tolerate it, you had to go back to taking multiple puffers. And because Trelegy is a dry powder inhaler, which we will learn about next time, it has to have a fast, rapid breath. So depending on where you're at with the severity of your lung disease, sometimes taking in a big, fast breath isn't possible. So that's where Breztri came in handy. Now, Breztri is a triple therapy with a slow breath that you take with the same spacer that you use with your Ventolin. And if both of those didn't work, there is Enerzair. So Enerzair is also a triple therapy. It's a fast breath because it's a DPI. So what a time to be alive. We have 3 options now for triple therapy. And we are getting to see this prescribed most commonly with the addition of a rescue puffer, whether that's Ventolin or Atrovent. So switching gears a little bit, we're going back to anti-inflammatory side effects. So if you're at the point in your management of your lung disease where either you and your family doctor or you and your respirologist are doing some trial and error to try and find the puffers that work best for you, it's really important that you're watching for these things if you're taking a puffer that has an anti-inflammatory in it. The 2 most common things that we see are sore throat, hoarse voice, or change to your voice quality. The sound of your voice, the loudness of your voice, that will change. Usually within a couple weeks, if not a couple days of taking the puffer. If you notice that, it's a side effect of the anti-inflammatory specific to that puffer. So don't keep taking it. Go back to see your doctor or specialist and find another puffer that might not cause that. Okay, and it's actually more common than you think. And it's actually, I see quite a bit that people have been on the same puffers with a hoarse voice for a very long time, and you shouldn't have to put up with that. So there's lots of options on the market, and they can always change you to something else. Thrush. So anti-inflammatory, or the corticosteroid that sits in your mouth, increases your risk for thrush. So this is why it's really important that after taking a puff of any puffer that has an anti-inflammatory in it, you rinse your mouth. So it doesn't really matter what you do with the water or liquid that you rinse. You can swallow it, you can spit it into the sink. Just you have to get that anti-inflammatory out of your mouth. Okay, and some people are more susceptible to thrush than others, but as a general rule, myself in my own day-to-day practice, I rinse my mouth out after every single puff of any puffer that I take so that I'll never forget. If you can remember which ones have anti-inflammatories and not, and you're like, nope, I only rinse my mouth with Trelegy and I don't have to with Ventolin, I got it, it's totally fine. Hey, that's perfect management, right? So in high doses, bruising, osteoporosis, and cataracts. So we'll talk about oral anti-inflammatories next, and this is typically where you'd see this more systemic effects. Oral anti-inflammatory. So the most common one that we see is prednisone. So this is the big gun. This is the strongest systemic anti-inflammatory that you can get. Typically, this is paired with an antibiotic for management and recovery from a pneumonia, chest infection. So it may be used to treat exacerbations in pretty much any lung disease. Must be taken as prescribed, and typically it's short term. So the idea is, I have an infection, the inhaled anti-inflammatories I was taking are no longer doing enough. I need to bring out the big guns. Short term, we get in there, we deal with all of that inflammation, and then we get out before you notice any of the systemic side effects. So 5 to 14 days, 5 to 7 is a little more common, it seems, whereas your antibiotic might be 7 to 10. So long-term, depending on your lung disease severity and the trajectory, whether or not you get recurrent infections, sometimes low-dose maintenance prednisone may be prescribed to keep those exacerbations and those chest infections at bay. So typically we see 5 milligrams, 10 milligrams as a maintenance dose, although higher is sometimes common, but some of the add-on therapies that we'll learn about in a bit have helped to reduce long-term prednisone use, which is a good thing because when we learn about the side effects, there's some big ones. So if you're taking maintenance prednisone, you may also be on calcium, vitamin D, and hormone therapy, and that's to help mitigate some of the systemic side effects you may experience. Here's some of the side effects. So short-term use, increased appetite, stomach ache, high blood pressure, mood swings, fluid retention, and insomnia. Long-term, weight gain, stomach ulcer, skin thinning, bruising, muscle weakness, osteoporosis, diabetes, and cataracts. So that's a big list, right? So that's why we don't want you to be on prednisone unless you absolutely need it. And when we do give it to you for management of a chest infection, it's short term. Get in, get the job done, get out. Okay. Oh, glaucoma. All right, here is an add-on therapy that can be used to treat COPD with associated chronic bronchitis. So when we talked about respiratory diseases, we learned that chronic bronchitis is associated with a lot of mucus, right? So mucus sitting in the airways, leading to airway obstruction, also increasing your risk of chest infection exacerbations. Daxis specifically treats phlegm. So it is appropriate to trial Daxis if you're having a tough time with a lot of phlegm despite being adequately hydrated, using your coughing and huffing techniques, and maybe even mucus removal devices such as an Aerobica. So a trial of Daxis, not everybody tolerates this, but I have seen this work quite well to reduce the amount of phlegm you have to deal with. Some of the side effects of Daxis, nausea, dizziness are the two most common ones. Typically, a little bit of nausea and dizziness recovers and resolves in about 3 to 4, maybe 5 days. Tremors, irregular heartbeat, sleeplessness, diarrhea, and depressive mood are other side effects. So it's worthy of a trial if you do have a lot of phlegm. So talk to your respirologist. This would be respirologist driven as it is a specialized add-on therapy. Talk to them about Daxis and have a conversation. Antifibrotics. So for treatment of pulmonary fibrosis, we learn that this is the progressive formation of scar tissue in the lungs. Antifibrotics help to slow and or halt that scar tissue production. There's Esbriet, which is an oral tablet. Some of the side effects include sun sensitivity, nausea, and dizziness. A little more commonly prescribed, we see Ofev. So that's also oral. 1 capsule 2 times a day. Some of the side effects are diarrhea and nausea. So these are worthy of a trial if you do have pulmonary fibrosis, and these can work quite well to slow the progression of your lung disease. Alpha-1 proteinase inhibitor. So this is for the treatment of alpha-1 antitrypsin deficiency. We learned that with alpha-1 antitrypsin deficiency, these people are lacking that protein in the blood that helps to protect the lungs and the liver. So prolastin C helps to mimic that protein. So it helps to give your lungs and give your liver that protection that it was lacking. It's a venous injection. Some side effects may include fever and dizziness, lightheadedness. So other respiratory medications, these are add-on therapies for the treatment of severe allergic asthma. Lots of testing has to be done, and there are strict criteria whether or not you're a candidate. So we have anti-IgE. So immunoglobulin E is released during a allergic attack. Xolair can help to combat the effects of that. IL-5 is also another allergic pathway. These guys are also called biologics. So Nucala, Fasenra, and Cinquer can help to halt that allergic pathway in the lungs, thus making your breathing better. And for treatment of allergies and asthma, we also have Singular and Accolate. So those are pills that you can take. And generally speaking, once you start any of these add-ons for allergic asthma, the need for your rescue inhaler goes down and your overall breathing improves. So it's really good for management. Antibiotics. So do antibiotics treat viral or bacterial infections? If you said bacterial, you are correct. So they do not have an effect on viral infections. Depending on what you have, sometimes antivirals might be introduced, but more importantly, time and your body's immune system will fight viral infections. There are many types of antibiotics available. There are actually 6 classes of antibiotics. This is why you're given something different for a urinary tract infection than you are for a upper respiratory tract infection or a chest infection or pneumonia. It's amazing how they know. You take them orally and they just know where to go. These must be taken to the last pill. So it's the human condition to stop taking the thing that makes us feel better as soon as we start to feel better, right? But the way that antibiotics start working is they kill the weakest bacteria first. So it's the strongest bacteria that are standing on that hill saying, "You'll never take me alive." And if you stop taking the medication at that point, those strong bacteria will now start to multiply. You will get what's called a rebound infection, which may be a lot worse than the initial infection, and that might actually require you to go into the hospital. So we do not want to do that. So a good way that you can help to combat that is take all of your pills, every single one, okay? And you're usually feeling almost yourself with about 2 to 3 days left in that pill bottle, and you got to just stick with it, okay? Flu vaccine. So it's highly recommended for people with chronic conditions, low immunity, and healthcare professionals. We are involved with caring for the sickest of the sick. So we must protect ourselves and we must also protect them. It's taken annually by injection. So every year they take a look at different markers and trending values, and they help to predict which type of flu will be the most spreadable during that year. And they cover those strains in your annual flu inoculation. So every year it looks a little bit different. Most of the time they're almost bang on with their predictions. So they are really good at trending what's going to be the most common flu strains. It can't be given when you're sick. When you're sick, your immune system is actively fighting an infection, right? So what a vaccination does is it basically gives your immune system a dry run to help prepare for whatever's in that vaccination. So all of the different flu strains, it's giving your immune system the information to be able to recognize and effectively fight off those incoming infections or viruses, right? So this is why we get what's called an immune response. So if you've ever had a vaccination and you feel yucky afterwards, you would maybe mimic having the flu or kind of feeling kind of achy, maybe a little bit of a temperature. That is called an immune response. That is what we want to see. So it's a common misconception that a vaccine makes you sick. It doesn't make you sick, but it gives you an immune response. So by your immune system firing up, that's the dry run. So even though it sucks to feel yucky after you get a vaccination, just know that your immune system is functioning regularly. And after that kind of 1 to 2 weeks after the vaccination, you are protected. If you don't get a response, so for example, my dad has an autoimmune condition called Wegener's. He does not respond at all to vaccinations. No sore arm, no yucky feeling, nothing. His specialist said it's likely that vaccinations are not as effective because you need to have an active immune system in order for vaccinations to help you prepare. So it's really important that everybody in my dad's life, everyone that he comes into contact with, stays up to date on their vaccinations so that we can protect him. That is essentially what herd immunity is. We all are protected, so the ones that are less protected, whatever is going on in their life, maybe that's they're not a candidate for vaccine or they have a low immune system, so that they are also protected. Okay, so the recommendation is always to get it, especially for my dad, even knowing that it's not quite as effective. So what do we mean when we're talking about vaccine effectiveness? So for example, if it's 80% effective, that means that if you get the illness that the vaccine was covering you for, your symptoms will be reduced by 80%. It does not mean that you are now immune to getting whatever you're vaccinated for. It just means that you will probably be able to recover at home feeling yucky versus go into the hospital for an extended stay. That's huge. We don't want to go into the hospital, especially with a chronic condition, because your risk of getting other infections is through the roof. So recovering at home, feeling a bit yucky, but having a more mild version because you are covered with the vaccination, that's the goal. That's protection, right? And for some reason, the flu vaccination still has eggs in the making of it. And so if you're allergic to eggs, then you are a candidate to get it. Pneumonia vaccine. So this prevents illness caused by pneumococcus bacteria. So the most common types of pneumonias recommended for people with chronic conditions, low immunity, and anyone over the age of 65. Did you know that after 65, your age is a comorbidity? So even if you're perfectly healthy, after the age of 65, you now have a comorbid condition, meaning your age is now increases your risk of dying prematurely. This isn't recommended if you have had a reaction to any other vaccines, obviously, and a booster is available in special circumstances. So this says 10 years after the original dose. There are actually multiple pneumonia vaccines on the market now. My best recommendation is talk to your pharmacist. They will be able to pull your vaccination records, determine which one you had in the past, and when you are eligible for a booster. Okay, there's once every 5, once every 10, there's a one and done. It's hard to keep track of them all, but it's good because we have options, right? So talk to your pharmacist. I had a guy yesterday say that he deals with home care. He has his home care come in and deliver it. Perfect. Yeah, there's more than one access point of healthcare professionals to be able to pull your vaccination records. They're all available on our computer system. So the moral of the story, know your medications. Take notes when getting instructions, especially if you're in the trial and error phase. Maybe your doctor or specialist has been switching up your puffers to try and find a regimen that works for you. You may have different device types. You may have different techniques to take all of those medications. It's really important that you have a good understanding of how to take that puffer, because Otherwise, you're wasting your money. If you're not taking it appropriately, your lungs aren't going to see that full dose and it's not going to be working as well. Maybe you feel like you need to take more. It's a waste of money, and puffers are expensive. Ask questions when you visit your physician or clinic. Depending on how much time your doctor has this, they may not be the best resource for puffer specific questions. I would say talk to your pharmacist. In my opinion, pharmacists are the least utilized, but the most knowledgeable healthcare professional on your team. Talk to your pharmacist. Most of them are absolutely delighted to talk to you about the medications, go through with you how to use them. Just make sure you have good understanding. Okay. So, confidence and motivation scale. How confident do you feel to take your medications as prescribed? This includes the proper dose and the right timing to manage your symptoms. If you are less than 5, that might mean that we need to have a conversation. That's okay. If you are like, Sarah, I've been on the same medications for 20 years, I was taught how to use them, I'm confident in using them, then maybe your confidence is 10. But if you look at the requirements for graduation sheet, respiratory medications is on there. So if you are really confident, you have no questions, no side effects, no anything like that, let me know and check that off. If you're not so confident, maybe you want me to watch your technique, maybe you need to talk to me about it. You have the opportunity during this program to receive that support, to build your confidence, to be able to check that off. And it has to be checked off by the end of the 8 weeks in order for you to graduate. So take the initiative, reach out, let me know what you need, and I will be happy to work with you. Okay? So to summarize, take your medications correctly. This will help reduce your symptoms and will prevent the progression of your lung disease, especially if this is exacerbation prevention we're talking about. There are many types of pulmonary medications. You and your physician will decide which one works best for you. Sometimes this takes a little bit of time, some trial and error, and some patience, but once you get on the regimen that works for you, that's it. You take them as prescribed and you're good to go. Side effects may be minimized with inhalation. That's talking about oral prednisone versus inhaled anti-inflammatories. So next time I speak to you, we'll be talking about proper inhaler technique, and there's always tips and tricks you all can integrate in order to tweak and improve your puffer technique. So there is an awareness exercise in section 6 of your binder. I don't need to see this, but we will be building on this when we talk about building our breathing action plans. List your medications that you take for lung disease. This is puffers specifically. So if you're not on any puffers, don't worry about this. You have the chance to circle whether it's a bronchodilator, inflammatory, or maybe both. And is this bronchodilator fast acting? So if you're writing Ventolin or Atrovent, yeah, it is. Oxys, yeah, it is. Anything else? Nope. Alrighty. So get those down. It'll help you with your overall awareness and confidence about your medications. And that, my friends, is it.